Good afternoon. Thank you to the organizers for asking me to speak. Lovely to be back in the Middle East. Okay, here are my disclosures. As you can see, I have to disclose that I am on a number of guidelines. So the two guidelines that I like to focus on today are the just freshly published RCOG guidelines. So this is from the Royal College of Obstetricians and Gynecologists in the United Kingdom. So this is a guideline that's been about 10 years in gestation, really. So it took a very, very long time to get this sorted. I will also be showing some slides from the American Thyroid Association guidelines. Now, these are not published, these have not been approved. So some of the slides that I'm showing you are preliminary, and some of the recommendations therefore may not follow through. So I've got permission to show the slides, but don't sue me afterwards if the recommendations change. So I don't think this audience needs to be told what happens to thyroid function in pregnancy, but just as a reminder for all of us, there are a number of physiological changes to thyroid function. As you know, as HCG rises in early pregnancy, this coincides with a decrease in serum TSH. And that is because HCG is structurally very similar to TSH, and so what you get is a stimulation of the thyroid gland, which will result in an increase in circulating thyroid hormones, and as a consequence, TSH will go down. As a consequence of high levels of estrogen, thyroxine-binding globulin will increase, and that will result in an increase of total T3 and T4. Thyroid antibodies generally reduce during pregnancy, so thyroid autoimmunity improves. And the fetal dependency on maternal thyroxine really is most pronounced in the first 20 weeks, which is why it's really important that we get thyroid function right during that period. And then from about 20 weeks, the fetus will have its own thyroid gland and will start producing its own thyroid hormones. As pregnancy progresses, you will get increased deiodinase 3 activity in the placenta, resulting in T4 degradation, and there's also an effect of renal iodine clearance, which again will increase through pregnancy. And it's really important that we remember these physiological changes when interpreting thyroid function. So as you will see at the bottom of my slides, when it's an RCOG recommendation, I've got their symbol there, and so the guidelines are online, but they're still in press, so I haven't got the full reference yet, but so they are available from the British Journal of Obstetrics and Gynecology. Again, this is not really new what's being proposed in these guidelines, but there is a sort of ongoing debate that's been going on for quite a few years now, which is whether we should do screening of thyroid function in pregnancy. And so both the British and the American guidelines are going to recommend against universal screening of thyroid function in pregnancy. What is recommended, however, is that you use trimester and manufacturer-specific reference ranges. So it's really important that you know on which assay thyroid function tests are determined when you look after these women. This may all be well and good that we tell you to have very specific assays for pregnant women. If this is unavailable and if you don't have appropriate information, then generally it's recommended that you use a normal TSH reference range between 0.1 and 4. And it's also really important to consider that treatment targets are not the same as reference ranges. Okay, treatment targets can be different. It's not because you aim to keep a serum TSH below 2.5 in someone on levothyroxine that is your normal reference range for someone who is not on levothyroxine. What we have done together with the biochemists in the British guidelines is for the most commonly used assays, we give what are the accepted reference ranges depending on the trimester in pregnancy. And again, this may be useful for some of you. So this is published and publicly available. So what we did in the American Thyroid Association guidelines, and so there's been, as you can imagine, it's a huge group of people who are contributing to these guidelines. There's been a lot of debate, shall we say, as to who should be tested and whether we should test. But so what we did as part of this, and this is just recently published in Thyroid Now, I'll look at when we don't do universal screening, if we do targeted screening, which actually are the risk factors. And I think for a long time people thought that women with a higher BMI, etc., that they would be more likely to have thyroid dysfunction. And actually there were very few, when you look at all the evidence together, so this is a very large systematic review of all the available evidence, but there are actually not that many risk factors that will identify patients at risk. So anyone who has had a previous history of thyroid dysfunction should receive a thyroid function test. And also, whilst we don't recommend that you screen for thyroid antibodies, if you know that someone is TP antibody positive, then it is probably appropriate to check thyroid function at least up to 20 weeks of gestation. If someone has typical symptoms or a goiter, or someone on medication use for thyroid dysfunction, then it is appropriate to do thyroid function test in each trimester. There are a number of pre-existing conditions, but I think what's important for us here are those with infertility or multiple pregnancy losses. It is appropriate to screen those patients at presentation. Don't continue to screen, but do it at presentation. If there is a family history of autoimmune thyroid disease, and then again in areas of iodine insufficiency, it may be appropriate to do thyroid function testing. Right, I will just go through the various thyroid conditions now. But so overt hypothyroidism, what we have to remember here, and of course we're not going to get a trial of treating or not treating someone with overt hypothyroidism, that would clearly be unethical, but data on untreated overt hypothyroidism are more than 20 years old. What we have seen in the last 20 years, however, is that more and more women receive thyroid function testing, but actually finding true overt hypothyroidism with a TSH greater than 10 is very, very rare in pregnancy. And the estimated worldwide prevalence of this is about 0.15%. If there are mild abnormalities in thyroid function, these are unlikely to be truly overt, and the majority of gestational hypothyroidism is mild. And you have to remember that you can also get a falsely low free T4 in pregnancy. So what has been clearly documented is that for many women in pregnancy, even if TSH is mildly abnormal at the start, it probably without any treatment will normalize, and that is true in a large proportion of patients. So how do you manage someone who is overtly hypothyroid and on levothyroxine replacement? Well, it's always important to prevent problems from happening rather than waiting for them to happen. So this is our protocol in my pregnancy clinic, where we try to mimic normal physiological changes. So if I have the luxury of knowing that someone is trying to become pregnant, that's about 50% of patients that I see, then adequate preconception replacement, so a TSH less than 2.5 is appropriate. We do empirical dose changes, so anyone of childbearing age who may become pregnant, if they're on levothyroxine, I tell them double the dose on 2 days of the week once you become pregnant, as soon as you have a positive pregnancy test. Don't wait for a thyroid function test, don't wait for a renewed prescription, just whatever dose you're taking, double it on 2 days of the week. I monitor on a 4-weekly basis until 20 weeks, and if things are stable then, they only get it once per trimester, so at 28 and 34 weeks. And I do predictive dose adjustments. I don't wait for serum TSH to go well above 2.5 before we make an adjustment. If this if the TSH is approaching 2.5, I will increase the dose, and vice versa, reduce as needed. I tell women to continue the same dose they were taking in the 3rd trimester for 2 weeks following delivery, because those increased binding antibodies will remain high for about 2 weeks. What we do recommend in both guidelines, so this is both RCOG and what will be recommended in the ATA guideline, is if someone is diagnosed in pregnancy and you've started them on levothyroxine, it is worthwhile trying to take them off levothyroxine following delivery. So you could stop it following delivery and recheck around 6 weeks postnatally. Oops. Sorry. Right, I think what is more at the forefront of our mind, and I think certainly women treated for overt hypothyroidism, it's relatively clear what we should do with them, is what we should do with subclinical hypothyroidism, and whether we should treat or not treat. And so, of course, a number of adverse effects of subclinical hypothyroidism have been studied in detail, and most of these studies actually come from Tim Korovar, who has kindly lent me quite a few of these slides. But So the first question is, does subclinical hypothyroidism, is it associated with preterm birth? And what these forest plots here show that indeed subclinical hypothyroidism is associated with, sorry. I'm trying to go back here. Yeah, there we are. Is associated with preterm birth and also with very preterm birth. But when you look at the absolute maximum differences in someone who has euthyroidism or who has subclinical hypothyroidism, you can see that this risk difference is actually quite low. So it goes from 5% to 7.1% for preterm birth and from 0.8 to 1.9% in very preterm birth. So absolutely, in risk difference, this is quite small. Very similar data for having small babies, so this is small for gestational age babies. Again, you can see that in subclinical hypothyroidism there is an association, but the maximum absolute risk difference again goes from 10 to 11.8%, so quite small differences. And the question then is it worth treating? Similarly, for subclinical hypothyroidism, an association, and you can see these inverse bell-shaped curves here for both TSH and free T4. And again, there is an association with subclinical hypothyroidism, but in absolute terms, the risks are quite small. And again, then looking at offspring, so these were all pregnancy risks, but looking at offspring and child cognition, I think we're all aware here of data showing that both the free T4 at the lower end and at the upper end are not good for the fetus. But when you look at the maximum free T4 effect, this accounts to about a maximum of 4 IQ points, and you can see again here this inverse shaped curve. And then again, when a meta-analysis was done that at all the studies or the database studies that have looked at an association between subclinical hypothyroidism and poor cognitive outcomes, there was actually no lower IQ identified. Now, this is one of the few areas in the field where we actually have some trials. So there have been 3 trials performed. The bottom one is actually a combination of a number of studies that have been published. The 2 main ones are the NIH trial and the CATS trial, where patients or women with mild hypothyroidism, so subclinical hypothyroidism or isolated hypothyroxanemia, were given levothyroxine. The red bars indicate at which point during pregnancy levothyroxine was started. So you can see in the NIH trial, this was quite late, really 18 weeks. In the CATS trial, this was 13 weeks. And the earliest trials that have started it were the trials from Iran, where they were started at a median of 12 weeks. Now, the only studies where there is a slight hint of a positive effect are the Iranian trials, where there was a lower preterm birth rate and a better motor score. However, when you take all these trials together, there is probably insufficient evidence and insufficient trial evidence that giving levothyroxine in these women actually has an effect on child cognitive outcomes. One of the criticisms, and I take that, is that for many of these trials, probably levothyroxine replacement was started too late, and what we would need are some trials where we started really very early on in pregnancy, but we do not have those data available. And then, of course, the question is, does it do any harm? And I thought that for many years, that I thought, you know, what's the harm giving a little bit of levothyroxine to a woman? I may have a benefit, I may not. The data aren't really clear, the absolute differences aren't high, but am I doing any harm? And actually, I think there is a signal now that by giving overzealous levothyroxine replacement, this may cause harm. So this is a database study. I think I've already shown this before to this audience, but essentially it provides very important information. So this were 5,000 women, so it's a registry, 5,000 women with subclinical hypothyroidism who were given levothyroxine, and you can see that what's indicated in green is that this had a good effect on pregnancy loss. However, it was associated with an increased risk in preterm delivery, gestational diabetes, and preeclampsia, so not without harm. And then I've already shown you the CATS trial. So the CATS trial was a trial in the UK where women with subclinical hypothyroidism and isolated hypothyroxanemia were given levothyroxine. They were given a fairly high dose, so 150 micrograms of levothyroxine. And as a consequence, a lot of the mothers actually had a high free T4 concentration. And what you can see here, so this is the graph on the right-hand side, is that there was an association between women who had the highest free T4 concentrations and then ADHD in the offspring. And then on the left-hand side, these are data from the Danish database, where again you have this inverse U-shaped curve, where you can see that both with low and high free T4, there is actually an increased risk in ADHD. Further studies have also linked this to autism and epilepsy, so again, further evidence that overdoing this with levothyroxine replacement probably is not in people's best interest. So, and this is draft. So it's not been approved, it's not been ratified, so if you take this, like I said, this may change. But what the American guidelines are going to recommend is that you make this trimester specific. So previously there was no distinction before if you would or wouldn't start treatment. But so if TSH is normal, so this is assuming an upper limit of the reference range of 4, then you wouldn't treat. If it's between 4 and 10 in the first trimester, then you consider treatment. And if it's greater than 10, you would treat. Now, that's something you would do in the general population anyway. You would treat a serum TSH that's greater than 10. However, in the second and third trimester, what we recommend is that possibly no treatment is needed. And that is based on sort of further analysis of all these association studies that have been done. However, what we do say is that the cutoff between the first and second trimester is not a hard 12 weeks point, and that some poetic license can be applied there. And again, that this cutoff of 10 isn't a sort of a very hard cutoff. And this is a busy flowchart here. Again, it's in draft form, but if you have an increased serum TSH, then it's appropriate to check TPO status, because we know that those who are TPO positive and have a raised TSH are more likely to progress. Like in anyone, you would then, if TSH is increased, you would check free T4, and if this is low, then you have overt hypothyroidism. Now, you have to bear in mind that these guidelines were produced by, like I said, a panel with a lot of discussion, arguments, online meetings, and that we didn't necessarily always agree. In my opinion, if you have an increased TSH and a low free T4, you should treat. However, what these guidelines are likely going to recommend is that you treat if serum TSH is over 10. Now, you have to put this in the context that the American Association of Reproductive Medicine have suggested that you do not treat anything unless serum TSH is over 10. So I guess previous guidelines would say definitely you treat over 4, so this guideline is sort of taking a middle way. But so what we're proposing here and what's going to go out to the general public is treat a serum TSH over 10. If it's less than, treat a serum TSH over 6. If it's less than 6, then maybe repeat serum TSH after 3 weeks and see if it normalizes, because indeed for a large proportion of patients it will normalize. If serum TSH then, if you confirm that serum TSH remains raised, that you then start levothyroxine. If it normalizes, then no further follow-up is needed. And similarly in subclinical hypothyroidism, if it's in the first trimester, again you may consider confirming it, and then start low-dose levothyroxine as appropriate. So what are the key messages here with regards to mild hypothyroidism? Do remember that a large proportion will spontaneously revert to euthyroidism. The risks of untreated subclinical hypothyroidism, as I showed you with all those absolute risk differences, are actually quite low. We should reduce overtreatment as well as the patient and healthcare burden that this proposes. And what is new in the ATA guidelines is no need to treat after the first trimester, although this is not strict guidance. But do remember this thing, and I am now increasingly doing this, where I find someone comes with a serum TSH of 4.5, and there is nothing else there to point towards thyroid disease. I often repeat this within 3 weeks, and I tell you, certainly the anecdotal evidence from that is that usually it normalizes. Okay, hyperthyroidism then. This will be shorter, you'll be pleased to know. It's really important again here that you do preconception counseling. So it's important that you get this right before the patient becomes pregnant. What both guidelines emphasize is that you do a risk stratification for Graves' disease. We will still stick with using propylthiouracil in the first trimester, although, of course, for these guidelines, we have a panel of representation from all over the world, and what's become clear is that in China and in South America, PTU is not available. So we can make all those recommendations, but if PTU is not available, then you're a bit stuck. So you may consider stopping anti-thyroid drugs when you have a positive pregnancy test, and my next slide will come back to that. And generally a cutoff of TSH receptor antibodies that we consider as significant is 3 times the upper limit of normal. So certainly in my clinic, anyone who has ever had Graves' disease, regardless of what treatment they've had, regardless of what their current status is, I will check their thyroid function and TSH receptor at the first time that they come to my clinic. So why do we prefer PTU? And again, I think I've shown a number of these slides to this audience before, but that is because the risks of the teratogenic risks associated with PTU are lower, and there tend to be more correctable defects. So with methimazole or carbimazole, you will generally get a sort of a syndrome of complications or teratogenic effects, and they are more difficult to correct. With PTU, they are milder, such as a hydronephrosis or preauricular cyst, so milder and more easily to correct. But again, here, the absolute risk difference between PTU and methimazole, when you look at all the studies that have done and combine them together, goes from 3 to 5%. So again, this is not massive, the difference. PTU is not without risks, but they are lower. And like I said, they're generally less severe. And so the main studies that have looked at that are given at the bottom of this slide here. So how about discontinuing anti-thyroid drugs? So this is again a figure in draft that will likely to be incorporated in the guidelines. So you will see that the new ATA guidelines are going to be quite colorful and pretty with lots of pretty pictures. So they're shorter than the previous ones. You've had not 300 pages of text, but shorter, more figures, and sort of more succinct advice for people, so you don't have to read through 300 pages before you may or may not find what you're actually looking for. Anyway, so the risk of Graves' hyperthyroidism relapse increases slightly in the first trimester, but then comes down, and that is because TSH receptor antibody concentrations will come down. Of course, your teratogenic period is here, and therefore you may consider stopping anti-thyroid drugs altogether if the patient has been on treatment for a minimum of 6 months, if serum TSH is normal, so no longer a TSH that's below normal or undetectable, if they're on low doses of methimazole, so less than 10 milligrams, if there are no signs of orbitopathy or goiter, and if TSH receptor antibodies or TPI, whatever you use, are less than 3 times the upper limit of normal. So where do we take this TRAB level of 3 times as low risk? So this is here actually quite a nice study that has looked at all cases of fetal and neonatal hyperthyroidism documented in the literature. And essentially, when this was meta-analyzed, the lowest TRAB concentration associated with fetal or neonatal hyperthyroidism was 3.7 times the upper limit of normal. So if TRAB is less than 3 times, so when I do it, when patients come to my clinic and it's less than 3 times the upper limit of normal, generally no further repeat is needed. That is assuming that the mother has her thyroid, that she's not had radioactive iodine ablation, and that she's not had a thyroidectomy. Because if this is an athyrotic patient, then that requires a different interpretation. But mother well controlled biochemically and has a thyroid, and TRAB is 3 times the upper limit of normal, and this then generally no repeat is needed. If that is not the case, or if the patient is actively treated with anti-thyroid drugs at 12 weeks, then I would repeat at 20 weeks, because at 20 weeks I need to decide how closely do I monitor this fetus. Does this need regular growth scanning? Does this need fetal goiter detection? And at 28 weeks, I would then repeat, because that's going to predict who needs neonatal input. Because if they're high, more than 3 times the upper limit of normal at 28 weeks, that baby is more likely to develop neonatal thyrotoxicosis. Again, we have a draft proposed flow chart here, so pretty similar to the previous one. So this is a suppressed serum TSH in pregnancy. If that's the case, you check your circulating thyroid hormones. If they are normal, this is subclinical hyperthyroidism and unlikely to require any intervention, but you may want to repeat it after 2 to 4 weeks. If you have overt hyperthyroidism, you would check TSH receptor antibodies. If they are negative, then probably not much to be done, maybe a little bit of monitoring. If they are raised 3 times the upper limit of normal, then the recommendation is that you treat for Graves' disease. If they are not 3 times or more the upper limit of normal, then again you could do monitoring, but the target should always be to keep serum free T4 in the upper half or the upper 30% of the normal range. With regards to monitoring, so these are patients, like I said, in hypothyroidism, my patients get monitored on a 4-weekly basis. Actively treated hyperthyroidism, those patients get a 2-weekly thyroid function test in my clinic because I don't want to overdo it. And when you stop or switch the dose, again, fortnightly testing is appropriate. Targeted in the upper 30% of the reference range, and I do serial, or I ask someone to do serial ultrasound scans from 26 to 28 weeks onwards if there was uncontrolled Graves' disease at any time during pregnancy, if they required anti-thyroid drugs, or if TRAB was 3 times the upper limit of normal. Moving on then to thyroid autoimmunity, and again, some of these slides here have been shown to you before, but a further analysis looking at maximum risk differences in thyroid autoimmunity. So this was Tim Korva's seminal study in JAMA in 2019, but you can see that women who have positive TP antibodies would have an increased risk of preterm birth, as is shown in this forest plot here. And this is more pronounced when serum TSH is greater than 4. Again, here though, the absolute risk difference is small, goes from 6.5 to 7.1%. So what happens if someone has positive TP antibodies and is euthyroid? So this is a follow-up study from the tablet trial, which I'll show on my next slide. So the tablet trial was a trial where women who had raised TP antibodies but normal thyroid function were given levothyroxine. And we then followed them up subsequently, and you can see that in 8% of those who had normal thyroid function but raised TP antibodies, they developed hypothyroidism. For the majority of patients, this was subclinical, and it was only a minority that had overt hypothyroidism. But when you looked at the whole tablet trial, in those given levothyroxine, unsurprisingly 2% developed overt thyrotoxicosis. Usually this occurred early on, so they developed thyroid dysfunction within 6 months during follow-up. And if this was during pregnancy, then this was again mostly in the first trimester. So this leads to a recommendation that if you know someone is TP antibody positive and has normal thyroid function, that monitoring of thyroid function test is appropriate. So these are the 3 trials that have been done and that have led to the recommendations. So the previous ATA guidelines say to consider levothyroxine replacement in someone who is euthyroid and is TP antibody positive, especially if there are fertility issues. That is not what will be recommended now and is not what's recommended in the RCOG guidelines. So these are the 3 trials. One is from China, where women undergoing egg transfer, IVF egg transfer, were given levothyroxine. Euthyroidism was a negative trial. This is the T4 Life trial from the Netherlands. Again, women with recurrent miscarriage were given either levothyroxine or not, and you can see that this was a negative trial. And similarly, the tablet trial here was negative. So women with a minimum of 1 miscarriage were given levothyroxine. 940 women were randomized. I was part of this trial. I looked at a lot of thyroid function tests. Again, a negative trial. Giving levothyroxine made no difference. And in particular, when we looked at subgroups, it made no difference depending on the number of miscarriages they'd had, whether their serum TSH was less or greater than 2.5, and whether they were undergoing infertility treatment, because this was for women who'd had a minimum of 1 miscarriage or were undergoing investigations for subfertility. So what will be the recommendations, or are the recommendations? So routine testing for TP antibodies in women who are euthyroid is generally not recommended in pregnancy, But if you know that someone is TPO antibody positive and euthyroid, then offer to monitor thyroid function test, because I showed you the data, the follow-up study from the tablet trial indicating that women are likely to become hypothyroid. It's not recommended for women who are TPO antibody positive with normal thyroid function during pregnancy, and this will be a change in the ATA guideline, and this is regardless of whether TSH is in the reference range or not. So don't just treat thyroid autoimmunity, we don't have a good treatment for it. I'm not going to dwell on thyroid nodules and cancer. The advice that we're giving in the guidelines, I was part of the subgroup that worked on nodules and cancer, pretty similar to the 2017 guideline. And the emphasis here is do the same thing as you would do outside pregnancy. So the target TSH reference range is the same as in pregnancy. What will be different compared with outside pregnancy is if you diagnose someone with, for example, a small thyroid cancer at the start of pregnancy, that you could withhold treatment for 9 months, because it is not going to impact this person's overall prognosis. And if you're uncertain, then certainly in the United Kingdom, this will be a multidisciplinary team decision. But again, we will emphasize that there is very little risk associated with withholding treatment for 9 months. If immediate surgery is required, and again, this is a change, what I'm trying to highlight on this slide here are the changes from previously. We've always been told you can only do this in the second trimester of pregnancy. There are now new guidelines in the United States from the anesthesiologists that actually you can do thyroid surgery at any point in pregnancy if required. Ideally in the second trimester, but if you need to do it in the other trimester, and this doesn't just apply to cancer, applies to Graves' disease as well. If you have to do it at any point during pregnancy, then you are good to do that. So here are my key messages, nearly done. So risk assessment of women at booking and determine whether thyroid screening is needed, and very few women actually will need thyroid screening. Not new, but used trimester and manufacturer-specific reference ranges, but a relaxation of the recommendations with regards to treating mild hypothyroidism and generally TSH greater than 10. If they have overt disease, optimize their thyroid function test pre-conception and in early pregnancy. There is no need to routinely test TPO antibodies in pregnancy. And you may test it, you may find it, and then you don't have a treatment. So generally it's best not to test. You can check TSH receptor antibodies, but you would only repeat it and do subsequent monitoring if this is 3 times or more the upper limit of normal. Thank you very much.